It's a pleasure to address the audience again. I've enjoyed the meeting, and it's good to see such a good crowd here on Saturday morning. So I'm going to talk about uterine factors. The title says for pregnancy loss, but this can be for anything really in OBGYN. So we're going to talk about imaging methods for the uterus, the most common congenital and acquired problems of the uterus, and then some surgical methods that are used. Just for very brief review, the development of the reproductive tract occurs during usually 6 to 8 weeks. It's completed by 10 weeks. The fallopian tubes, the uterus, and the upper third of the vagina. And from my residency, this is what we knew AMH. If you didn't produce AMH, the reproductive tract developed. Now we know we use in reproductive medicine AMH for ovarian reserve all the time. This schematic shows in blue the Mullerian tubes as they start about 5 weeks. They have to come together down at the bottom. They fuse together. And then where they fuse down in the lower portion, the wall in between dissolves, and we know enzymes now that are involved in this process. And then the body of the uterus forms. So any problem that comes from this process that doesn't work, you're going to have one of the Mullerian tract abnormalities. If it doesn't elongate, if it doesn't fuse, if the septum doesn't resorb, then you're going to have a developmental abnormality. We are using now, definitely for pregnancy loss, almost exclusively the sonohistogram, 3D sonohistogram in our office. I talked at one of the pre-congresses and was surprised to find not so many people are doing this. How about in this group? How many are doing the sonohistogram in your office? Very few. You have an ultrasound in your office? Where do you send them out to the hospital? What do you do for ultrasound? What is it? Well, we would recommend do the sonohistogram in your office because it's easy. We did a study more than 10 years ago. In the red, the patient, the same month we offered them a hysterosalpingogram and a sonohistogram in the same month. And then we had them do a test. What was their comfort level? The red, you see it's higher with hysterosalpingogram. Cramping, pain, dizziness, everything was better with the sonohistogram. Now, this is perfect for the pregnancy loss patient because already she's getting pregnant. But for the fertility patient, we still are doing hysterosalpingogram to check the fallopian tubes, of course. These are some of the images from the 3D sonohistogram, normal arcuate pattern there on the top right, and then different versions of the septum and the bicornuate. The advantage of the sonohistogram is you can see the absence of the tissue, whereas when you look at this one on the hysterosalpingogram, you don't know what is it. You can't see is there muscle here, is there a dip here or not. So this same patient, when we did on the sonohistogram, you can see very nicely that the fundus is normal and that this tissue is the septum. So on this one, just for the talk, I got an MRI, but we don't do MRI very often on these patients. So if we now look in this paper, we studied over 900 patients with recurrent pregnancy loss, and we just listed what's the frequency of abnormalities. We broke it down into congenital problems, about 6.7%, and acquired problems, about 13%. And you can see the various factors between the congenital and the acquired. The most common of the congenital, of course, was the uterine septum. And this is from a meta-analysis looking at different patient populations, unselected, infertile, recurrent miscarriage. large studies were put together, and then they looked at the prevalence of congenital uterine anomalies. And you can see still in women who've reproduced, 5% will have some problem, but it didn't affect them. Infertile patients, higher, 8%. And then recurrent miscarriage, 13%. And if they have both problems, miscarriage and infertility, the frequency of problems is higher. So it's, of course, important to image the uterus. We mentioned the septate uterus is the most common congenital anomaly. It occurs about 10 to 1 more frequently than the bicornuate uterus. And it results in a high pregnancy loss rate between 30 and 65%, depending on which study you look at. We think simply that the placenta can't attach well, it can't get vascularization, and then the pregnancy fails. We generally fix these with hysteroscopic repair, and I have some slides in a minute I'm going to show you. So we also looked at our patients, and we divided them into two groups. We divided them into this primary recurrent pregnancy loss. These are the couples who never had a live-born child. And then secondary recurrent miscarriage. These had a baby and then had miscarriages. And when we looked at all the problems, congenital and acquired, the only one that we saw a difference, you can see I circled, is the septum. The uterine septum occurred twice as frequently in women with primary recurrent pregnancy loss than secondary. And this makes sense because the bigger the septum, the harder it would be for these women to successfully carry a pregnancy. Now, this is a case of a woman that had a septum and history of 3 miscarriages. Sometimes on laparoscopy, first you notice a broad-based fundus. It's wider than you would normally expect. And sometimes you see a blanching area. It's a little bit lighter in the middle here. This can suggest there's an underlying septum. This is the hysteroscopic view. You can see the ostia on the right and on the left, and the big septum in the middle. And I said usually I cut these with scissors so that as I cut, I can get down to where the point of it starts bleeding. You know you've got down to the healthy tissue, but this one was resistant to the scissors, and we had to use electrical coagulation. It's a little loop that we cut, and we've cut maybe halfway through the septum here. You can see the cavity starting to open up. Always check your ostia. You don't want to burn or cut these here on the left, and then again on the right. And then this is the final view of the cavity once it's opened up. And then we tell the patient, wait 1 or 2 months before she tries to get pregnant again, so there's a chance for the uterus to heal. Now, the unicornuate uterus is probably the least common finding that we see of congenital abnormalities, less than 1%. You have to remember these women also have a high frequency of developmental problems with the urinary collecting system, because these both structures, the reproductive tract and the urinary tract, develop in the same time frame, 6, 7, 8 weeks, 5, 6, 7, 8 weeks of gestation. How do we treat these patients? Usually, if they haven't had pregnancy loss, we measure the cervical length. People are worried if it's below 2.5, and maybe our MFM experts here can say what's the condition here. Maybe the same, 2.5 centimeters. If they've had pregnancy loss, many people are putting a cerclage, but there's great debate on this. And then if they have a rudimentary horn, most people believe this should be resected. These are just some diagrams of different simple non-communicating horn, communicating horn. This one here often will present when the patient starts with menses. She'll have lots of pain, particularly if there's blockage of the fallopian tube, and you'll have to go and make surgery to correct this. This is the sonohistogram image of the unicornuate uterus. You see the lighter part of the cavity, and you see the outline of the uterus here. And sometimes you can be fooled with this because it compensates. It becomes the size of a normal uterus. You can't tell unless you do a careful evaluation. The bicornate uterus, it's about 1% of congenital abnormalities. Single cervix, but two separate communicating horns. And sometimes you can be fooled, and some people think there's two cervixes because the separation can come all the way down. This is an MRI, and you can see here from the coronal view the two cavities and the lighter area, the endometrial tissue. And then here on this frontal view, you can see the definite split, no muscular tissue where the arrow is. So you definitely don't want to go and start cutting this with the hysteroscope. This will be a big problem. So I was trained whenever we resect the septum, we always should do a laparoscopy at the same time just to push the bowel out of the way and make sure you don't injure any tissue. This was one of my patients from, more than 10 years ago. She had bicornate uterus, and when we put in the laparoscope, we saw this band of tissue from the symphysis pubis to the sacral promontory. And you can imagine that the two tubes never could come together to fuse. This was just a mechanical blockage. Okay, finished with the congenital anomalies. Now let's look at the acquired anomalies. These include adhesions, fibroids, and polyps. When we looked at our patient population, over 1,000 patients, or maybe this was 900 patients, I think. Yep. We divided them into 2 losses versus 3 losses because there's been some controversy on recurrent miscarriage. When should you start evaluating the patient, after 2 or 3? Now all the guidelines say 2, but this was just to confirm. The acquired anomalies, the frequency was the same, whether 2 or 3 losses, whether it was adhesions, fibroids, or polyps. And we judged polyps significant if they were greater than 1 centimeter. We also looked at primary versus secondary. You remember primary are the couples who did not have a live birth. Secondary had a live birth. And again, the frequency of the acquired anomalies, 14% in primary, 12% in secondary, it's the same. No significant difference in the frequency of any of these abnormalities. So now looking at each of the acquired problems, adhesions, there are many causes, DNC, prior surgery, infection, sometimes C-section or prior hysteroscopic surgery can result in adhesions. We classify these in a simple classification as mild, moderate, and severe, depending on how much of the uterine cavity is involved and how their menstrual cycle is affected, whether it's not affected or it's decreased. Again, this is a sonohystogram. You have coronal view, sagittal view of the uterus, and then you can see here band of adhesion, another band of adhesion here. The cervix is down on this end. So this one also we recommend hysteroscopic surgery. This is a study looking at what's the result if you don't operate, and then 2 studies that looked at after surgery. So if you take patients who have adhesions and you don't do surgery, their chance for recurrent miscarriage is up to 40%. In this one study of over 500 patients, after cutting the adhesion, it dropped to just over 20%. In this study, almost 400 patients, it dropped to just under 20%. So we tell the patients your chances will be doubled if you cut the adhesions. What about fibroids? As I showed you before, we see equal frequency in primary and secondary recurrent pregnancy loss. We consider, I think most groups consider the submucosal fibroids to be the most significant, and we think it alters the contour, the vascularity, and the ability of the placentation to occur. Again, this is a hysteroscopic surgical repair. We know that fibroids are abnormal cells that lose control of their development. They become unregulated. From some of the studies, we know that these are probably stem cells that start as the first cell that loses control. And we know a lot about the regulatory genes and genetic abnormalities. Now, we don't do genetic tests on fibroids. I'm not recommending it, but for research studies, people have done chromosome analysis on fibroids, and many of the fibroids in different ethnic groups are genetically abnormal. There's a regulatory gene, HMGA2, and this gene is controlled by MED12. MED12 normally suppresses this regulatory gene, but when MED12 is mutated, the suppression is not there and the cell continues to grow unregulated. So many of the fibroids we know are from a genetic mutation and then from mutation in the MED12 gene. This is just an image of, we have an electrical loop. We always go back behind the fibroid and cut towards the cervix in shreds, and then go and pull the shreds out with the polyp forceps or some other instrument. Similar studies have been looked at for what's the outcome before and after resection of the submucosal fibroids. There are 3 studies here. Recurrence rate in most of the studies was around 80% of miscarriage, and after resection, after myomectomy, you can see in all 3 studies the recurrent miscarriage rate dropped dramatically. Now, there are no studies, which would be ideal, of like a prospective randomized study where you take the patient and tell her, we're not going to operate on you, and the other one we're going to operate. So there are limitations to these studies, but nonetheless it appears useful, and most of the guidelines recommend this type of surgery. Now, moving in the last acquired anomaly to polyps, again, here's a sonohistogram. This is the outline contour of the uterus. The dark is the saline infusion, and then here you see a large polyp occupying a good portion of the cavity. This is definitely one that we would resect. It's still controversial. Our guidelines from American Society of Reproductive Medicine and ACOG consider polyps as not significant, but we feel if anything over 1 centimeter that's occupying such a large part of the cavity should be removed, and we find this in over 3% of our patients. So to summarize the uterine anomalies, congenital anomalies are found in about 6.7%, acquired anomalies in about 13%. So the point is, it's very important to evaluate the uterine cavity for women with pregnancy loss and definitely who have problems with fertility. The septate uterus is the most common congenital anomaly and is associated with the highest incidence of reproductive failure. We recommend 3D sonohysterography, and for those that aren't doing it, we know that patient satisfaction is better. She stays in your office. It's a more comfortable procedure, but it's not as good at evaluating the fallopian tubes. And then as far as pregnancy loss, you shouldn't distinguish between primary and secondary or necessarily the number of losses. All the patients we recommend have a uterine cavity evaluation. Okay, thank you very much.